be a few. I think I will start. Anyway, I'd like to really thank the NIA for its leadership during this time, as well as NAC and Bud, who's been working with us extensively, the clinical task force under Alan Levy, and really all of the centers. This is really all about you all. And originally we had a presentation put together that was going to focus on lifestyle factors, social determinants of health, and care models. And we got a great response from all the centers, had a fantastic program on, and then wham, hit by COVID. And we thought—
I think I'm on.
Very good. Thanks, Mary. And we thought at this time that we really needed to focus on the ADRC response to this COVID crisis. So that's what we're going to focus on today. Can I have the next slide? So what we can think about this in several different ways. I also want to thank all the centers for answering the survey that we had sent out, really looking, back in March, early April, where were we at that time? And now we've had several weeks. We know where we are now, exploring flexible but uniform processes and really looking at short-term solutions. Of course, the clinical task force over time is looking to develop the UDS 4.0, but this was a starting place for us. Next slide. So the survey results from the ADRCs, again, early April, we had 30 of 31 centers responded. So I think this is very representative anyway. And there were a wide range of responses. We'll take a look at that data. Remember, the slides will all be posted. Next slide. So we really focused on current status of the ADRCs, and this really shows us, and I'd really like you to look down at the bottom. Full in-person UDS participation was essentially zero at the time that we put this out. Sites still engaged in some respects, but obviously a dramatic change from normal. Next slide. So there were a few areas that seemed to really reach general consensus throughout, and that was a general expectation that our ability to conduct traditional UDS in-person visits is going to be delayed by more than 3 months, possibly 6 months or more, possibly even longer. We really don't know. But we are at a point where some centers, I can say mine, is already looking at potentially in the next month or so getting back up and running, as long as we don't see a second wave. Biomarker collections almost completely shut down, with the exception of a few sites collecting if they are related to safety measures in other affiliated studies. Of course, everybody knows that NAC has a window for annual longitudinal visits of plus minus 6 months, and the majority of sites really follow that, although some sites have more stringent requirements for their annual visits, narrowing that down to even less than 3-month windows. And we're really going to see an impact of COVID with that kind of narrow window structure. We may have more time for the sites that have more flexibility in their visit windows. Irrespective of visit windows, we know that almost 2/3 of the ADCs are going to have trouble meeting NAC visit windows without an alternative plan. It was nice to hear that ADRCs are doing their best at social distancing, with virtually 100% of ADRC staff working from home. Some, 14%, have been redeployed, preventing them from working on ADRC initiatives, but the majority still focused on our efforts. Next slide. So there are some areas where there was less than consensus, and this is a slide that basically looks at those survey results and says, well, what approach should we use with some centers recommending pausing until we can resume traditional evaluations. Of course, this would protect our legacy data. Many centers favoring using the telephone visit follow-up packet, and that is a strategy that we're moving forward with, as you'll hear about today. Lots of sites stressing the need for flexibility, but essentially 0% of the centers that were polled favored anarchy and just doing whatever we want. So very, very important. Next slide. So the situation was, can we develop a uniform approach? Should we develop a uniform approach? And the majority of centers favored a uniform approach. We do see a number of centers that said, hey, we just got to do whatever we got to do right now. And a large number of sites deferred to other, suggesting a mixed approach, but certainly favoring some sort of unifying theme for what we do. And so that was really the task that we confronted. Next slide. So there was this consideration of how could we remotely monitor our research participants, and I think that there are some concerns about that. 55% of centers felt that before we can recommend remote monitoring of participants, we probably need to collect more data, and yet we've seen from the previous discussion that in a very short period of time, we are going to lose critical longitudinal data that we might be able to recoup if we really leverage some of the strengths and the science that we're best at. Next slide. So let's talk about the wealth of experience that we have. Next slide. So it's quite interesting. Almost half of centers are already using remote data collection for non-UDS NAC projects. So it's clear that we do have experience in this area. Next slide. So looking at modalities, and there were a variety. We looked at mail-in surveys, telephone assessments, smartphone app-based assessments, video conferencing-based, web-based, and other methods out there. And we do see large numbers of centers, 86% of centers, familiarity using telephone assessments, and a large number of centers, 64%, having used telemedicine and video-based methods. It doesn't mean that these are the best methods or the most optimal, but it does mean that we have experience that is quite heavy in these areas. Next slide. We also asked what modalities were favored for the future use of data collection. And again, telephone-based and or video conferencing-based assessments seemed really to rise to the top. And this really helped us put together some of our thoughts as a clinical core steering committee and the clinical task force that we're going to focus on today in terms of developing an approach for the future, at least the immediate future. Next slide. So there were many comments, and I think that this is important. And with those comments, there were caveats, but also a promise, a silver lining in the cloud anyway, and that while this is a difficult time and we do need to be cautious, there are many opportunities at this time. And really, we might want to think about embracing technological advances that are available to us all, much as Elizabeth and Maggie have done with Bud to put together this meeting today. Let's take advantage of this difficult time to develop some tools that may be helpful in the future. But the caveat, we really need to preserve the integrity of the data we worked so hard to collect over the years. There were thoughts that really using remote technology may help us in some ways reach out to new populations, reach out and establish cohorts in states that may not have ADCs because we could do that remotely, target underserved populations, especially those in rural and remote areas. And this is really considered profound, as well as really the wave of the future and a unique opportunity to innovate. So I am always an optimist, and I like to look at it in this fashion, but I do think that we need to be cautious about some of the caveats that were presented. Next slide. So I'm going to make up for lost time by ending very quickly today, but I wanted to give you the overview and flavor. These are my favorite comments of all that we received. Number one, you know, what we do together. We may do it at our individual sites, but it is our strength and unity that makes the ADC initiative so great. And so developing a shared plan is important. Also, just tremendous team spirit. Happy to pilot anything the team needs. My favorite comment, of course, is that the survey was especially thoughtful and well done. Thank you, whoever wrote that. We were doing our best to try to gather some consensus thoughts. And of course, always looking out for one another. Comments from one of our respondents, please stay safe and healthy, everyone. So next slide. With that, I really want to introduce the agenda today, where we should be focusing the conversation. And so our agenda is really going to move into the clinical task force members and then some review of different remote monitoring technologies from a variety of different centers that are really going to represent the center-wide experience. We're going to start with Andy Sakin and Lisa Barnes, who are the co-leads for the Cognitive Working Group, present on recommendations for remote telemedicine, telephone-based cognitive assessment and related items. Cindy Carlson, who is my co-lead for the Clinical Measures and Diagnosis Working Group. We'll talk about the recommendations for the non-cognitive components of the UDS 3.0 telephone follow-up visit battery. And then we'll address what we know, what our experience is in telephone-based data collection with Susan Kraft, telemedicine video-based collection with Mary Sano, app-based data collection, Rhoda Ah, and web-based data collection with Jeff Kay. And then we've saved ample time, hopefully, as long as we stay on time today, from the last half an hour or so, we'll have open discussion. None of the decisions have been finalized. We really wanted to take the opportunity today to get feedback and open this discussion, but we are eager to move very rapidly into implementation of some of our initial thoughts. The Clinical Core Steering Committee and the Clinical Task Force are not bodies that dictate from above. We are representatives of all 31 ADRCs, and we are here to come up with the best solutions that help us all do our work and continue the progress that we've made over the last several decades. So with that, I think that's my final slide. We're going to understand current recommendations and our expertise. With that, Lisa and Andy, the floor is yours.
Yes, thank you. Can you hear me?
We can.
Okay, great. Just wait for the slides to come up. Thank you. Good afternoon. I'm Lisa Barnes from Rush, and I have the pleasure, along with Andy Sakin, of presenting the Cognitive Working Group update for the Clinical Task Force. Next slide, please. By way of a brief outline, I'll start with a brief description of the mission of the Cognitive Working Group, including our short and long-term goals. Then Andy will discuss the proposed UDS3 telephone cognitive battery that was emailed earlier this week to all of the clinical core leaders and directors. And then I'll end with a description and rationale for a proposed COVID-19 questionnaire. Next slide. So our neuropsych work group includes 6 neuropsychologists representing different centers, different expertises, and experience with different populations. Our original charge was to plan for the UDS4 cognitive battery. But given COVID-19, we ended up having to rapidly change course and come to a consensus on a UDS3 cognitive battery that could be administered remotely. Next slide. So just to give you some background on our charge for UDS4 planning, following on the footsteps of the working group led by Ron Peterson, our group planned to take into consideration all of the really great feedback that the former working group provided and review existing UDS3 measures to reduce battery length and allow room for more sensitive measures for preclinical stages, including digital computerized tests and wearables. With feedback from all of you, hopefully, and the many center affiliated studies, we hope to identify optimal measures that will align well with existing paper and pencil tests, potentially pairing novel and conventional tests for each domain, and of course, taking into consideration cost, technology, compliance, and special populations. Some overarching principles that we also plan to consider is we will have close coordination with the clinical work group. We'll select measures that allow redundancy and economy of scale, and we'll pay special attention to the importance of capturing item level data for analysis and harmonization. Next slide. So we were set with these plans and had a pretty aggressive timeline for our deliverables, hopefully by the next ADC meeting in the fall, and then COVID-19 happened. So Andy will now talk about the pivot that we had to make to address the crisis. Andy?
Hello, everybody. First, many thanks to the members of the cognitive subcommittee and to the whole clinical task force for working so quickly. We had multiple calls within a very short period of time to organize this response. I'll say more about the Wake Forest group that were so critical in this shortly. Essentially, where usually if you have a group of neuropsychologists in a room discussing tests, achieving consensus would probably happen over a number of years. This happened within about a week. So quite impressive. And I think we really came together with the team spirit that Greg and others have commented on. Essentially, also, much of the current UDS battery does lend itself to telephone or video conference-based assessment. And fortunately, those tests could be adapted pretty quickly, especially given all of the prior work that had been done by the Suzanne Kraft and the Wake Forest group. So essentially, the protocol is on this slide. It's about 30 minutes. This is our consensus recommendation endorsed by the cognitive group and the broader CTF. And it's basically the very familiar items to many of you, especially from the clinical course, the Kraft story. The MOCA, basically there's a blind or telephone-based version of the MOCA that just leaves out the visual items. So it's very easy to adapt to phone or video conference format. Number span, forwards and backwards, the fluency items, including category fluency for animals and vegetables, the delayed recall of the Kraft story, and then the geriatric depression scale. All can be administered in a format, and this is our recommended core battery. So these are basically a straightforward translation right out of the existing UDS3. So it's almost plug and play, although obviously there's some details to move into a telephone or video conference-based format. You have, well, all on the director mailing list and clinical core leader mailing list have received a very detailed packet, cover letter of explanation and a very detailed manual of operations for the test battery, covering a lot of the considerations. In terms of feedback and questions, specific questions related to the UDS3 T-Cog, as we're calling it, should basically be directed to Suzanne Kraft at Wake Forest, and her email is on the cover letter transmitting this protocol, and I'm sure you know how to reach her. More broad-based questions about assessment in terms going forward, and especially the planning for the UDS4 could be directed to the co-chairs of the cognitive subcommittee, which Lisa Barnes and myself, and we'll make sure that those get addressed. But short-term questions related to the T-Cog protocol go to Dr. Kraft. Next slide. In addition to that 30-minute core battery, there are several other tests that are recommended, but these are considered supplemental and are optional, yet we think they're a good fit and they are recommended. So first of all, there had already been quite an impetus to have auditory verbal learning tests administered across the center's program, yet a recommendation that centers are doing different tests. Some use the CIRAD, CVLT, the Hopkins verbal learning. One of the more widely available tests used in many protocols in the centers and in other NIA programs is the Ray AVLT. So that's the recommendation, but the other verbal learning tests are also acceptable. But use of at least one of these AVLTs is strongly recommended. And of course, this does also lend itself to telephone-based administration. The manual that was distributed does cover the Ray AVLT, but again, others could be substituted. In addition, it's harder to do executive-related tests beyond verbal fluency over the phone or video conference, but one of the measures that's been used in a number of telehealth neuropsychology approaches is the oral trail making test. This is a brief measure that instead of the written format of trail making basically involves rapid counting from 1 to 25 as the analog for trails A, and then rapid verbal sequencing 1A, 2B, 3C for the alternating component that's part of trails B. So it's not clear that the exact same domains and dimensionality are tapped by an oral version of this as the written. In fact, it's probably unlikely, but it seemed important to include some executive measure if possible, and this is quite brief and does have some, although it's a limited sample size, there's some validation data available in MCI and AD compared to controls. The other supplemental test that's recommended, since we can't do visual confrontation naming, is a verbal naming test. There are also some similar alternatives to the formal verbal naming test. This one may be possible in the future to shorten this, but we don't have the data for that yet. But essentially, this is production of a name to to a verbal stimuli. For example, the thing you put over your head when it rains, as opposed to looking at a picture. But it gives a fairly close analog to what we'd be tapping with the Mint doing visual confrontation naming. So these are the optional protocol that take about 20 to 30 minutes. The entire recommended protocol should be under an hour. And there's preliminary testing that's been going on at Wake Forest. And I'm sure we'll get feedback from other groups as well. So we very much like to understand the questions or concerns that people have to receive that feedback. Next slide, please. There are a number of considerations for administration. We recommend a video conference format if that's available, but telephone is acceptable. It's recommended that the examiner use a headset for fidelity, both for hearing and for speech production. It's very important to record the method of administration, whether it was a video conference format or phone-based assessment. One of the things that the committee discussed is the issue of participants that may not have access to optimal technology. That's a concern. It should be noted and use the best available technology possible for individuals. There's a screening protocol for hearing impairment, which obviously is very important. If hearing is more than minimally affected, then that's going to bias results and would have to be taken into consideration and may preclude a valid telephone-based or video-based assessment. Something that's very important for a future data analysis is complete recording. We're recommending that all centers use some type of digital recording, and guidelines could be presented in the future for that, but basically either through the computer or through an external digital recording device that would basically capture the responses and the timing of the responses of individuals as they're being assessed. It'll be helpful for quality assurance. And also, very importantly, it will preserve item level data collection that can be used for validation, battery optimization, and crosswalk studies in the future. I want to thank Paul Crane at University of Washington, a psychometrics expert who's offered to perform item level harmonization and validation analyses of the data when collected. Recommended order of administration is also available in the very detailed materials presented. And just a note that, many of the tests already exist in translation for centers doing testing in Spanish. Probably not all of that information, and that would be a work in progress, but certainly all of the NAC forms are available in translation. Next slide. And then because the GDS is included for participants along with the cognitive testing, there's also a recommended protocol for addressing the issue of elevated scores. And Lisa's going to talk about assessment related to COVID, but stress and depression scores could be elevated, and there's a recommended protocol for a brief suicidality assessment if necessary, and procedures for referral. Each clinical core and center, I'm sure, will have their own protocols for this as well, but there's some guidance that may be helpful. Next slide. And a major shout out of thanks to the Wake Forest team that several of us have mentioned today, but Suzanne Kraft as lead, and Steve Rapp and Bonnie Sachs as colleagues at Wake, who have been doing a lot of telephone-based neuropsychological assessment in many projects, had already begun working on a UDS3 telephone battery, but where they were just about to start pilot testing and putting things together, they ended up, I suspect, dropping everything else they were doing and going full bore to develop this very detailed protocol that you've received with all of the forms, instructions, guidance, and so forth. It was just an extraordinary Herculean effort, and we owe them a debt of gratitude. So thank you, and I'll turn things back over to Lisa to talk about the COVID questionnaire.
Thanks, Andy. So shortly after the states across the country issued their shelter-in-place orders, Rush began to work on a COVID-19 questionnaire developed by Patricia Boyle, the leader of our Rec Corps. With input from our executive committee, we ended up creating 2 versions of the survey, one longer survey that was to be put into the Rush Memory and Aging Project, and a shorter one that Dave Marquez and I thought would be more suitable for our cohorts with underrepresented minorities at Rush. And at Rush, we have 3 minority cohorts listed here on the slide. The survey was originally designed to be administered as part of a wellness check for our participants, all of whom are community dwelling elders. Most are cognitively unimpaired, and we wanted to be able to ultimately correlate these COVID questions with a wide range of existing psychosocial and decision-making questions. The final surveys ended up including questions that mostly focus on the psychological and financial impact of the pandemic. Next slide, please. And now, about 17 weeks into this crisis, COVID-19 has spread throughout our country with over 1 million cases and over 60,000 deaths to date. And it has become clear that this virus disproportionately affects older adults, people with chronic cardiovascular conditions, and racial and ethnic minority groups. In short, it's affecting the populations we work with in our centers in one form or another. And if not directly, at least indirectly, it is going to affect us by the way we have to change the way we run our lives now in response to living with this pandemic. Next slide. So in our clinical task force discussions, it was clear that we needed to capture the impact of this virus on our ADC participants. So I shared the shorter 16-item Rush questionnaire with the committee. With their feedback, I reduced it a few times in different ways, included some questions that could be given to a caregiver, and included questions to assess exposure and symptoms based on feedback from the committee. Next slide. And so working closely with the Clinical Task Force Committee, we came up with a revised 16-item questionnaire for the ADCs that includes not only the psychological and financial impacts, but also addresses the biological impact and includes questions about testing. And given the potential of a greater reliance on remote testing, we also ask about access to technology. There are 2 forms, one that can be administered to the participant if the CDR is 0 or 0.5, and one that can be given to the co-participant or caregiver if the CDR is greater than or equal to 1. The questionnaire is strongly recommended by the task force to help us capture COVID-19 disease burden and the impact on our outcomes of interest, including cognition, neuropathology, and other biomarkers. And as we heard this morning in the director's talk, there is interest by NIA in thinking about how these coronaviruses may impact neurologic outcomes. The forms will be translated into Spanish. Well, they were already translated, but we changed the form. And the final forms will be distributed to all centers with the hopes that we'll be able to do this over the phone while we're sheltering in place, and then continue to give this questionnaire once we return back into our offices. Next slide. So I will end with this slide. We've been talking about incorporating social determinants of health as part of our data collection for some time now. In fact, as you heard, the original agenda for this meeting included a session on social determinants of health and was to feature some really exciting work by centers who are already fully engaged in measuring the social determinants. I'm hopeful that we will be able to include some brief social determinant measures from categories featured here on this slide when we develop the UDS4. But I think we can, as we continue to discuss how to uniformly assess social determinants in a way that makes sense across all of our centers, adopting the COVID-19 survey now will not only allow us to examine the impact of COVID on brain health, cognition, and biomarkers, it will also give us the unprecedented opportunity to leverage any future social determinants data and understand the ways in which the stress of living with this pandemic will relate to and potentially exacerbate the effects of social determinants of health. So I'll stop there and hand it back over to Greg. Thank you.
Fantastic. Andy and Lisa, thank you so much for that presentation. We've received a number of questions. I'd like to ask the two of you to make sure that you stay online. I'd like to run through the agenda, and then again, we have 30 to 35 minutes at the end where we can move through all of the questions in a reasonable fashion. So with that, I'd like to introduce Cindy Carlson, who is the co-lead for the Clinical Measures and Diagnosis Work Group for her presentation. Cindy, the floor is yours.
Thank you, Greg. Can you all hear me okay?
Yes.
Yes, good. All right, thank you. So I really want to start by thanking my colleagues on the clinical task force. Again, Greg Jicka, Alan Levy, Andy Sakin, and Lisa, and all the members of the committee have really put in a lot of time. Really want to thank Greg's leadership for, especially for this component of our task force that's focusing on clinical measures in the diagnosis. And so I'm going to talk to you some about our work we've been doing in this working group. So next slide. So as has been presented before, again, what our task force is divided up into the cognitive working group, which Lisa and Andy just presented data from, and also for the clinical measures and diagnosis working group. So again, with this, the goal was to focus on, if you look at the blue box to the left bottom area, our task force and working group in particular was tasked with looking at some of the forms as we move toward UDS4 eventually, looking at some of the forms that gather information on symptoms, risk factors, and diagnoses, knowing that we really need to, as Lisa mentioned, expand our social determinants of health and capturing of that to better understand other factors that impact cognition in especially underrepresented populations. But again, with this goal of looking at these forms, if you can go to the next slide. Again, as Lisa mentioned, we have long-term planning goals moving towards UDS4. So again, maintaining the value of the longitudinal data, standardization, quality control, looking at burden on the participant and the center, looking at research efforts that really cannot be done at an individual study level, but really benefit from having the centers work together to collect data. And then, as has been mentioned, really trying to improve the racial heterogeneity and expansion of disease characterization in the group, looking at various behavioral, cognitive, motor symptoms so we can get a better idea of trajectories, looking at how to integrate electronic data capture, EMR, reviewing other measures to make sure they're reliable and are administered efficiently, such as with use of adapted design where they can gradually increase depending on how people respond to those questions, and then new instruments that could be piloted and validated before center-wide adoption. So as you look at these goals, though, again, with COVID, it's really kind of condensed some of the factors that we have to pull out of this that are to really think about how can we start collecting data now. So we didn't have the leisure of gradually planning for the COVID crisis. So again, shifted gears a little bit, but again, some of these principles come into play still, even with our thinking about our more acute short-term goals with data collection. So you can go to the next slide. So again, with the onset of this, our focus really shifted to the short-term guidelines and on remote data collection. So some of the ideas about doing validation studies, you know, again, we don't have that luxury right now to do the validation studies. We have to switch to things that are able to be collected remotely. We also want to make sure that we do have representation, even of those who are already in our cohort. So again, that's why there's been discussion about using telephones as opposed to video, because telephones, more people have access to telephones than video-based tools such as tablets, computers, or smartphones. So again, all these considerations have been factored into both the cognitive working group and to the clinical measures and diagnosis working group. So got a lot of the same principles went into some of our discussions. So as a task force as a whole, again, we felt the most urgent need was a telephone administered cognitive battery. So I really applaud Lisa and Andy and the whole team's input, and Suzanne, Mary, everyone on that team, their input on these telephone administered cognitive batteries. But then as we also wanted to make sure that we were capturing as much important information and valid scientific data through the telephone visit packet. So what we did was we looked at the UDS3, the current telephone visit packet, and I've shown that here on the left with the checklist that shows as of even before COVID-19, which items were required and which ones were elective or optional. Again, we always encourage teams, centers to collect all the data if they can, but recognizing that sometimes families on the phone may be fatigued or may not have all the information readily available. And so trying to identify which factors are most important to obtain on the phone during those telephone visits. But again, to emphasize that telephone visits are have been designed chiefly for people who were coming back for follow-up visits. That's one key point. And also for follow-up of people who are more advanced in their disease process. So these are really not designed well for people who are cognitively asymptomatic or very early in their disease process. It's usually people who've moved to a CDR of 2 or something and are now doing telephone-only visits. So again, that impacts who's being asked the questions. So again, a lot of the time on these telephone visits have to do with interviewing family members instead of the participant themselves. So, so Dr. Giga developed a modified Delphi method to really look at these individual items. And again, you can see the items that are listed here. And again, for the most part, everyone thought that most of these items were valuable. But again, whether some of them could be optional, we recognize that some already were listed as being optional. So for example, family history may not change that much, and maybe on a telephone visit wouldn't need to be reobtained at that point in time. Maybe it could be evaluated at the next visit if a person on the phone was too burdened from the interview at the time. So again, but most of these items when asked, people thought they were fine as is for the short term. You know, again, long-term goals with UDS4 may be different, but in the short term, we didn't see that there's a lot of value in changing or drastically modifying a lot of these items. You can go to the next slide. So again, most of the UDS3 telephone visit packet forms will likely remain as they are for the short-term period. Again, we'll be meeting still over the next several weeks to kind of finalize a recommended telephone visit packet to see if there's other changes that should be made. So changes that are still under consideration. So for example, should additional items be moved to the optional status? And again, this will be reflected on the NAC checklist. And then as Lisa's already mentioned, we're trying to, within the COVID questionnaire, really capture a snapshot disease burden and potential impact on general health, brain health, biomarkers, and cognition. So again, just really identifying, did the person test positive for COVID and or have symptoms associated with COVID, and then the severity of their illness. Not meant to do a full evaluation, but just to capture in real time if somebody did have the disease so that we can see what are the inflammatory reactions on their neuroimaging or their CSF biomarkers or their cardiovascular health that could affect brain perfusion. So again, trying to get a snapshot, not meant to be a study, but just to see which of our participants who are already enrolled in our center are have been exposed. And then trying to best capture physical exam findings over the phone versus video. Again, with a video, you can see if someone has a resting tremor, whereas with the phone, if you ask someone if they have a tremor, you're depending on the patient or the informant's input on that. And then use of telephone visit packets for initial visits. So again, this will be looked at later. We're going to focus on the follow-up visit first, but if this COVID pandemic progresses and there are resurgent waves, then we may be looking at a longer duration, and new studies and other centers may be trying to enroll new participants. So we may need to develop an initial visit that's a remote data collection. And then again, how to complete and document for a consensus conference using remote data. So again, as we look at clinical pathologic correlations, how to document that certain clinical assessments were done via remote data collection. So I will stop there and move on, pass the baton back over to Greg.
Fantastic. Cindy, thank you for that overview. Again, we'll address questions once we move through some of what we know from the modalities. And I was just delighted. I reached out to a variety of center members and co-opted them to, with a very short timeline, present a broad strokes overview today. Our first set of speakers are the group from Wake Forest. But again, we do recognize, and from the survey responses that came back, that there are a large number of telephone-based instruments that have been used by individual sites. And so really an overview of the validity and ways to assess telemedicine with Suzanne and Steve Rapp and Bonnie Sachs.
Great. Let me just introduce Steve Rapp, who is one of the core co-leads from our ADRC, and he'll start out by reviewing some of the background for telephone assessments that we've conducted at Wake, and then I'll pick it up and talk a little bit about our plans for next steps.
Great. Next slide, please. Great. I'm going to tell you a little bit about, as Suzanne said, the backstory, really behind each presentation of the battery, tell you a little bit about our experience with telephone assessments, some of the challenges and strategies that you will find incorporated into some of the materials in the battery. And then Suzanne will tell you where we're headed from there. Next slide, please. So our experience with telephone assessments began in 2007 when the Women's Health Initiative Memory Study, which was coordinated out of Wake, transitioned from face-to-face assessments to remote assessments. And so we had to develop a telephone battery, which we subsequently validated in a separate study that was published in JAGS. And we showed that whether you administer it face-to-face or whether you, or over the phone, you get the same comparable scores. And so that gave us confidence to move forward. Since then, well, we have administered that battery annually to 3,000 women for 12 years. So we've got over 18,000 administrations just of that battery. That positioned us then in two other studies, the COCO Supplement and Multivitamin Outcome Study for Mind, which is ancillary to the Cosmos trial. Laura Baker is PI. We've been using a slightly different battery in assessing over 2,000 women. And I'm not going to go over the scales, measures in them, but you'll see that some of them are in the UDS3. Next slide, please. The other trial at Wake that Laura leads is the Women's Health Initiative Sleep Hypoxia Effects on Resilience, or WHISPER study. That's 5,000 women that we're assessing multiple times, and we've got over 10,000 administrations of the same battery as we're using in Cosmos Mind. Then also the recently published results from the SPRINT trial have set up an extension of that, where we'll be using a telephone battery based on the SPRINT battery. Next slide, please. But an opportune coincidental event happened when about 6 months ago, the PREVENTABLE Study, that's the pragmatic evaluation of events and benefits of lipid lowering in older adults. It's a pragmatic trial, opened. That is, we started the planning year, and that's going to enroll 20,000 adults over 75 years of age. That'll test moderate intensity statin regimen against placebo, and will rely on the PCORNet and VA health systems. Being a pragmatic trial, there will not be in-clinic assessments, and so Bonnie Sachs and I, who are leading that assessment core, put our heads together, and we had to make a decision first. Were we going to try and train 150 or more people from around the country with unknown testing experience, or were we going to develop a telephone battery that could be administered from a core group of people at the coordinating center at Wake Forest? Well, that choice was fairly easy. The next choice was, well, what do we do for a battery? We've got a number of batteries going, and we, I think, wisely decided, let's use the UDS3 battery, develop a telephone version for preventable. That way, that aligns us with the UDS3 world, and that will be good for preventable, and it'll be good for comparing preventable results to other results. Next slide, please. Then came the pandemic, and you know the rest of the story. And the result is the battery that Andy presented to you a moment ago. There's several kinds of challenges that we have encountered in doing telephone assessments. They're listed here with some of the strategies that we've used to address those. Those are in the mop that you've received. Next slide, please. I won't detail these. You'll have them. You have the slides. You can look at them. But for time, I'm going to just move forward. So each of these, we've developed some kind of strategy for. This slide, the last slide that I'm going to show you, you'll recognize the UDS battery on the left column. The core battery, as Andy said, includes the tests, all the tests from the UDS3 battery that can be administered remotely. And then the third column is the core plus what Andy referred to as supplemental tests. These are possible substitutes for the tests that can't be easily administered remotely, and he has outlined nicely how to consider those. So at this point, let me turn it over to Suzanne to tell you what we are doing, planning to do at Wake and with you.
Thanks, Steve. Yes. So as Greg mentioned, we went through the results of the questionnaire that was submitted to all the centers. And although we identified a number of centers who said they were interested in telephone assessments, there were 2 centers in addition to us who are currently using them or in very close preparation. So UC Davis has basically the T-Cog up and ready to go, and they've been piloting it in an affiliated EPI study. And they're awaiting consensus from us about how to move forward in their cohort. And then of course, Rush ADRC is probably the best known for having a very long history of telephone assessment in their ROSMAP studies. Many of the tests, they're not identical to the UDS3, but they're certainly from the same conceptual domains. And then as Steve has just outlined for you, our experience. Next slide, please. So when we encountered the COVID challenges and knew we had to get off the mark quickly, we began pre-piloting, I'll call it, of the T-Cog. I'm not going to go over this chart in detail. It's basically the diagnosis is the first column, the age of the participant. Then it would be craft immediate in-person, craft immediate telephone, T-Cog. Those are the raw scores and the standard scores next to them. So to date, these are 7 participants. We've done roughly 10 to 12, just try to get our feet wet and figure out what the immediate challenges were going to be. And we have been pleasantly surprised that we've had relatively good concordance, good response from the participants, both cognitively normal and MCI. We did have encountered a little bit more resistance on the part of the AD participants. So we need to explore that further. And then there were some expected challenges, the hearing, acuity, and cheating, which our 92-year-old participant could be heard busily scratching down the items from the Ray ABLT, and we're starting to think cheating might be a resilience factor. We're looking into that. Okay, that's a joke. Next slide, please. So our next steps, we are in the process of embarking upon what we're calling a pre-validation and more extensive feasibility study, where we'll give either the core battery or the core plus supplemental test battery to 100 Wake Forest clinical core participants, half of whom will get it via phone, half via video, and we'll do a deeper dive into the feasibility of these modalities, try to nail down the biases, for example, as a video conferencing, selecting against underrepresented groups or other types of issues. And from this information, we hope that we'll be able to design the optimal protocol. And then we propose to convene a group of experts from the Clinical Task Force, NIA, other interested ADRC investigators to design a more formal inter-ADRC validation study for ADRCs that are interested in doing this. And the goal of that study at the end of the day would be a psychometrically sound, normed T and V-Cog batteries that could be used for remote assessment. I mean, our aspirational goal is to develop a method such that we could combine T-V-Cog and in-person test data in some meaningful, rigorous way, sort of the COG version of the Centiloid approach for amyloid imaging, but also that it would allow us to align our ADRC data with these ongoing large studies more easily, like the PREVENTABLE study, which could result in some exciting opportunities. So next slide, I'll just stop there and thank everybody on the CTF and NIA who have all, as Greg said, just been working together in such a great example of teamwork. So thanks.
Fantastic. Suzanne, Steve, and Bonnie, thank you so much for that presentation. So, the other side of the coin, and as Andy said from the Cognitive Task Force, video-based telephone or T-Cog assessment, interchangeable potentially in some respects, and yet there's a wealth of other data and experience with telemedicine or video-based conferencing. We have Mary Sano here with us today to present her insights into this modality. Thank you, Mary.
Great. Can you hear me? Can people hear me?
Yep, we can hear you.
Great. Okay, well, thank you so much. And I'm going to go right to the, first of all, I wanted to comment on the great help I got from Maria Loisos to put this together from our center. So if we could go to the next slide. I wanted to begin by both digressing and also comparing. We at Sinai have been conducting the telephone follow-up that Suzanne has described. We've collected it in over 50 patients. About a quarter of them are MCI, the rest are relatively normal. And I wanted to share with you some of the experience so we can compare this to what happens with video. What you can see here, by the way, is that the participants largely do not use their cell phones for this. They only use their home phones. However, what I think is also important is relatively high satisfaction with voice quality, personal comfort, and with the accuracy of the data. Again, you'll notice that the research coordinators are a little less convinced than the staff is. And if you go to the next slide, I thought it's also important to get the opinion of participants and what their experience is. First of all, most of the people that we reached had no one who could assist them, so a telephone was the only way to go. And the other thing that I think is important is in this battery that takes probably 40 minutes, satisfaction isn't the highest. It's only about 60%. However, what is clear is that there's no concern with the phone follow-up in which we do not record with the respect for privacy. So I think it's important to see we have a good possibility of using this. Now, I'd like to go on to the next slide, where I want to review why we think telemedicine is, or with video is so important. It really more closely mimics the clinical experience than a phone visit. And it's really had demonstrated effectiveness clinically in conducting sensitive physical exams, including neurological and in psychiatric exams, used quite widely. It has established utility in dementia management, and it's potentially cheaper and more convenient than an in-person visit. Most patients and providers are relatively unfamiliar with telemedicine, and that is a big problem that we really have to address. So let me go to our next slide. There are issues that I want us to consider. One is the acceptability and satisfaction with Tele-Video, and I will use some national information for that. I want to talk about reliability, achieving reliable data and diagnoses. Also, comparability. Is the data interchangeable with a face-to-face assessment? And detection of progression. None of that has actually ever been demonstrated, to my knowledge, from my review with telemedicine. Another really critical point is much of the telemedicine data that has been summarized is conducted with center to center as opposed to center and home, which is a very big and important issue. Additionally, the burden, both to participant and staff. This morning, I spent over an hour trying to get onto my internet. Maybe nobody else has ever had that problem. In addition, the sampling bias, who is excluded with the medium. I think these are really important. So in the next slide, I think it's important to note how rarely used this is. Only 4% of individuals over the age of 60 have had a telehealth visit. Not to say that more would not be willing to, and in fact, that's what this next set of data is about. This is from a national survey. The perception is that telehealth versus in-person has a much higher convenience. Clearly, it's either the same or better by more than 65% who say that televisit is more convenient than in-person. However, in other domains, feeling cared for, communication, time with a healthcare practitioner, or quality of care, the in-person is really rated much higher. It's important to realize, though, that this is for clinical care. And perhaps if you're thinking about research, the most important thing is convenience. I think it's also important to see that while my initial survey suggested that phone had no concerns about privacy among Latinos and African Americans, this is a major concern, privacy and confidentiality. So in the next slide, I wanted to talk about some opportunities. The neurological exam has been demonstrated to be very highly associated with in-person visits. The kappas for stroke evaluations range between 0.85 and 0.99, and that's a very clear neurological examination. I think there are some measures that are more difficult to do. Muscle tone is much lower. Language has a very high evaluation. And the one thing to note is that these are small numbers just based around the tiny part of the neuro exam, but the remote exam does take longer than an in-person exam. That's probably balanced by not having to go to a distant place, but it is important that as we extend how much we try to do remotely, it may not be reasonable to think it'll take less time unless, of course, we subtract the travel time. So the next slide. Okay, so I think teleneuropsychology is one of the things where we're hopeful because we want to be able to capture certain kinds of visual testing information. And I think there's some concerns that we may not fully realize when we read articles and look at data. It does clearly have very high comparability for discriminating diagnostic groups using both telemedicine versus in-person. However, there's some important limitations to consider. Most of those studies have used telemedicine in a clinic with standardized equipment as opposed to in the home. Very important issue. There's been minimal technical difficulty, and I think we all agree. How many times did you hear your stretched sound in today's session? And if you have only one repeat of information in a cognitive battery, that could actually be quite a challenge. The reliability has only been assessed with brief intervals, 2 to 3 hours, although the beautiful plan that Suzanne has laid out really demonstrates a good way to go about stretching the reliability, which I think is important. There's very little data on change over time. And there's really few studies conducted in-home or with different platforms to determine if there's comparability between platforms. And the next slide. So I wanted to just take a minute to talk about who uses and who is excluded. So I haven't even added race ethnicity to this slide, but I think it's important to think about the high potential for excluding individuals. If you just look at the center assisted, we're talking about the idea of an individual coming to a center where somebody would help them get online. Very helpful in rural and remote areas, very common in the VA and the CBOCs, or community-based outreach centers. In terms of home use, it could extend use, but it really requires resources and equipment, which will exclude potentially underrepresented and very old individuals. And if you look just at smartphone possession on the slide on the right side, what you see is only a quarter of the population with low income, with high school education or less, or even above the age of 75, are using these higher technologies. This is reiterated in the next slide, where we talk about what do people do with these technologies. I think it's really important to see how little, and I want you to notice that this slide unfortunately is a little garbled. The high age group here is only 70, and in our population, we know that we see individuals even older than that. So among the 70% who use smartphones, only 24% of those track health, and very few of them take video information from this source. The same phenomenon is true among those who are using computers. So if we go down to the next slide, I want to summarize. I think this idea of integrating telemedicine may extend outreach, and I personally would never even determine that I would need to know whether someone did the neuro exam remotely or if it was done in person. I think that level of data and the way we're scoring it currently is so ready to go via video. It's obviously increased convenience if the time is managed well. It can reduce burden. There's some comfort for the patient in being at home or the participant. Highly reliable diagnostically, especially for the clinical exam. Increased efficiency, fewer missed visits. This is a very big deal in our population. How often are people delayed by travel? I think there are some challenges, though. It's really a limited technology among our underrepresented groups. Everyone says they have a cell phone or a smartphone, but as I said, if they have a choice, they won't even use it to make a phone call. There's unknown reliability for in-home assessment. I think speech recognition over the internet may really hinder a cognitive assessment for an in-home versus an in-clinic kind of visit. Distractions at the site were noted frequently by my staff when they're using this. Somebody walks in the background, talks to them, especially in those who might have less resource. It's dependent on technology availability and expertise, and it really may reduce our likelihood of getting people to come in for biomarker characterization because they want to be assessed in their home. Nevertheless, I think there's a strong recommendation to begin to use it for clinical evaluation. I'm a little more reticent to say that's true for cognitive evaluations because of the unstable platforms, but we may be able to find a way to find more stable platforms. So that's my summary. Thanks.
Mary, that's absolutely fantastic. Great job covering, you know, the opportunities that exist before us, but also, again, those caveats. I really appreciate that overview. Next up, there's been a lot of developments in the field of app-based technologies, and one of the ADRC members that's really been driving this and on the cutting edge is Rhoda Oss. So Rhoda, tell us a little bit about the field of app-based cognitive assessments.
Sure. So I'm going to give this speech on our presentation, noting that enthusiasms for smartphone-based application was relatively low. So I'm hoping that after this presentation, enthusiasm, or at least interest in thinking about it and piloting it, will become higher. So if we could go sort of into the next few slides. So I just want to sort of point out as background, this is what we keep doing. We measure biomarkers, we measure genetics, we measure imaging, cognition, we keep refining our diagnostic criteria. And if we go to the next slide, this is what we keep finding. So we know that it's a disease Even in the preclinical stages, that's highly heterogeneous. We know that neuropathologically. Can you hit return? We know that in terms of imaging, and again, return. And we know that in terms of cognition. So going to the next slide. So what keeps happening? Well, at least from our drug trials studies, if we can keep hitting the return, we have not been finding effective cures for the disease. Although, and if we hit the return a couple of times, we certainly are starting to move toward promising findings. But what I want to do is sort of challenge us to think about what we can do differently than what we've already been doing. And that's why I think technology really gives us an opportunity, particularly remembering that this is an insidious onset disease where progression from asymptomatic to symptomatic is actually very gradual. And so if we can use technologies to sort of monitor on an ongoing basis, we may be able to, and can we hit return, to detect sort of that first negative trajectory of change. And I think that that's an opportunity that technology allows that our regular paper and pencil methods do not, or our sporadic ways of monitoring with these just annual in-clinic exams. So next slide. So why smartphones? So, well, there's 331 million people in the US, and it turns out that there's over 275 million who have a smartphone. So that's a 83.3% penetration rate. And this is very, this data I just picked up as being very contemporary. So if we can go to the next one. So what about the issue about the racial disparity divide? So actually the most recent surveys show, and can we hit the return? There's actually very little disparity between underrepresented populations and Caucasian populations in terms of smartphone ownership and use. So what about the income disparity, which I know Maria was talking about? And I just want to point out, the data changes very rapidly on this. So I did note that in her presentation, that was data from 2017. And I'm now looking at data that's really contemporary. So if we could hit the return, if we see there certainly is still an income disparity, but if you look at the penetration of use in smartphones and people who have low income, it's actually pretty high. And then if we could go again and hit the return. Now, it turns out that for some people, their only access to the internet is through their smartphone. And it turns out if we hit return, the people who are using smartphones for internet access are the less educated, and if we can hit return and return again, those with the lowest income, and then if we can hit again, those that are in the rural regions. So in fact, smartphones do offer us an alternative to reach some of the underrepresented populations that we've been talking about. Next slide. So what about the age disparity divide? So the AARP has been following this very closely. And again, this is very recent data. So if we can hit return, if you'll notice, the amount of uptake within the elderly population is increasing every single year. So in this particular case, we see just from last year, an increase from 70% to 77%. So if we can hit return. Now it's true, older adults are not early adopters of technology. That's not particularly shocking. But they do eventually adopt technology. And in fact, last year, half of them reported buying a tech item. And the most common one they buy is a smartphone. Next. Among smartphone owners who are elderly, they actually do report using their smartphones at high percentages daily. So this is a technology that's definitely penetrating, and it's definitely over time becoming more useful, and particularly for the populations that we're interested in targeting. So with that in mind, I want to introduce you to some of the things that we're doing on the smartphone basis, starting with, next slide, with the work that Jason Hassenstab has been doing at WashU. And so he has developed a cognitive application. And I think what I'd like to point out, or he liked to point out, so if we could hit return, is that, you know, he has some very simple principle, which is that there's the opportunity to test often and to do it much more robustly. Again, you hit return. We can actually do this in very short spurts. So unlike, you know, current cognitive applications, where we do assessments for 30, 40 minutes, you can actually do these in very brief spurts. And again, and then we can combine the results across these multiple sessions. So if we can go to the next slide, this just gives you sort of an idea, maybe if we could hit the return, you know, just an idea of what this looks like from the standpoint of a participant, where you can really customize it, and you can actually customize it to the preference of a participant as to when they want to take this. And if we can go to the next. And so this is just to give you an example of one of the tests. It's very, very brief, under a minute, looks at spatial working memory. And if we can hit return a couple more times. So this is an intervening test. You know, you look at the items, an intervening test, and then next. And then you have brief, and then they have to indicate where the items were placed. If we can go to the next one. And so this is an example of another very quick, again, this is, you know, literally under a minute, in which you can ask participants, this is a memory matching test, if we can hit next. And so here the participant just simply needs to view these items and then match it. And again, if we can hit return, there we go. All right, next slide. And then this is another associate memory test. Again, we have some items that we can present one by one, and then afterwards ask them what was the price, what was the information that was presented earlier. Again, we can. And I think the way that Jason has really set this up is very clever in the sense that it does bring in sort of a little bit of a gamification, not over the top, in terms of giving people feedback on how they're doing, giving them constant reminders, and give it, you know, and I think this sort of level of pseudo interactive reinforcement is very effective. Next. And then on top of that, he's been able to, through his own work, been able to build in some other adherence strategies that have been very effective. So then for the next slide, so now I just want to pivot sort of to focus on smartphone applications that are not necessarily just simply cognitive based. You can actually collect a lot of different kinds of clinically related information. And the platform that I was going to introduce is the Linus Health platform. Some of you might have heard me talk about this before. And I think that the number one thing on my end is that there is no one application that will cover all our interests and the kind of data we want to collect. It's actually going to involve multiple applications. And so the reason I use a Linus Health platform is because they aggregate multiple applications together. So from the standpoint of a participant, they only see this as one integrated application. So next slide. So this is just give you a sense of the dashboard from the standpoint of the participant as well as the administrator. And the next slide. You can do consent over the phone. Now the next slide. And you can actually present not just cognitive tasks, but questionnaires as well as other kinds of tasks. Next slide. And so, and you can even do things like paragraph recall. So in this particular case, it's pre-recorded, it's given to the participant, and now they tell back the story. And as you know, I have a lot of interest in the digital voice. And I have it because I think it gives us an opportunity to start moving toward testing that's culture and language agnostic. If we could hit return, because I think we're really trying to achieve representativeness. And the next slide. And actually, this is just the beginning where we can really use this methodology to achieve much more greater representativeness across the world. And why do I feel that way? If you could hit return. excuse me, can you hit return again? Already across the world, there are 3.5 billion smartphone users. And in the next few years, if we could hit return, that number is going to more than double. So if we're going to talk about a technology that has extraordinary penetration, it's going to be the smartphone. And so if we could, so I just want to encourage, I hope I convince somebody out there that there is opportunity to try to do things differently. And if we could hit the next, and to allow us to move in new directions. That's it.
That's fantastic, Rhoda. Thank you. Very exciting, very optimistic look at the future and how to really take advantage of this technology. We're doing well for a very packed session. Our last speaker before we turn to the questions is Jeff Kay, who will be talking a little bit about web-based cognitive assessments and their usage. Thank you, Jeff.
All right, thank you. Can you hear me? Hello?
Yes.
Yeah,
Okay,
we can hear you.
Thank you. All right. So I'm going to talk about web-based assessments, but really I think that the distinction in some ways needs to be expanded beyond the device to think more about the use case. It's not about the particular app or a computer or smartphone. It really has to center back to what are you trying to do. So next. And in that context, you know, the old what, where, when, why kinds of considerations are really important. So our immediate interest is to preserve our UDS data and perform now necessary remote assessments, hopefully temporarily. And, but ultimately, I think there's this opportunity that many people have already discussed to have novel assessments in the future, but that's going to take some work, and I'll sort of end with some of that consideration. When you think about these remote assessments, they can range from, are you okay? Just check in to portions of the UDS, which is actually what our telephone assessment right now that's being proposed is really doing, to much more novel functions like sleep assessments, socialization, life events, physiologic functions using digital kinds of tools at home. The baseline, the timing is important. You know, our classic baseline and then annual follow-ups has been followed for a long time, but as we've already, as Rhoda alluded to, going to more frequent or continuous kinds of assessments may be afforded by digital assessment. The ADRC population is very heterogeneous. I'll get to that in a second, as is the staff. And so who's doing the assessments as well as who is being assessed is really important. And then all of these considerations drive whether what you do in the short term or the long term. Next. So to get back to this idea of you know, what is the assessment? You know, a mobile app is really something that's on a mobile device, and it has certain requirements and some advantages and disadvantages from what I call a sedentary device, which is typically a PC or a laptop. But it's really about why do you want to use one of these devices, and it's really has to be determined by considerations such as the user experience, the development time, validation, and costs, things like that. Next, please. So considering some of these important areas, which the previous speakers have already talked about, so I'll quickly go through some of this. We actually don't have a lot of information about our ADRC cohorts in terms of their technology capabilities. How many are online, who and where they are, the devices they have or use. So just because you have a device, you may not use it. How proficient are they? And this also comes to the staff as well. So we need this more systematic data. At our center, we've been doing a tech use survey, and I might suggest that we consider going beyond just asking people if they have a computer or internet access going forward in the future. On the right is just the recent UDS NACS summary of our cohort, and it just shows the tremendous heterogeneity. Actually, we have a very educated group. When I really looked at these numbers over, in the controls, for example, 39% have 17 years or more of education, but that all of these, we want to include everybody, young and old, and so you have to develop for a large swath of the population. Next. This is just to remind us that, and I advise or recommend people review this article. It has nothing to do with the dementia cohorts. It's a younger group of people, a review of 8 studies using smartphone assessments frequently. And it's just to point out the incredibly low retention in these studies. So these were studies of sleep and Parkinson's and depression. And just to point out that just because people have smartphones, so these were people, younger adults mostly, doesn't mean that the device will be used. So again, getting back to this careful attention to the details of what what you anticipate when you're using a web-based or a mobile-based app. Next. Now, something I wanted to point out is there is experience in the ADC universe. Mary is modest in that she didn't raise this, that back in 2005, in the Mesocentric era of computing, was the home-based assessment study. And this study randomized people for those who don't remember, do a clinical trial to look at remote assessments, comparing human telephone assessors, telephone assessment using automated speech recognition, and a home-based, essentially a computer, touchscreen computer shown here, with some ASR assessment. And this was run over 4 years with a tremendous, actually once people were in the study, there was actually very good adherence. And tremendous things were learned about this. And I must say that one of the interesting things is the cognitive battery that was done remotely is almost identical to what it was done, is being proposed for the telephone battery. So there is a lot of experience in this area and lessons that we can apply going forward. Next. There's a lot of, going back to more specific tests, there's a huge universe, as people know, of what might be called cognitive apps. This is a recent review that people can look at, just looking at app-based and web-based self-testing, and an assessment by this group of their psychometric qualities and their performance norms and so forth. Not very, there's a lot of work to be done. Next. And these, and there are many more in development. I want to just point out a few. There's a SMART survey has been being developed by ADRC, this is a VA-based researcher in Minnesota. Another grid test, you saw one previously. 2 efforts that are linked, NIA efforts, the mobile toolbox, monitoring for cognitive function at Northwestern, or based in Northwestern, and the mobile monitoring for cognitive change, M2C2, that Marty Slowinski and colleagues are also conducting. So these should be considered perhaps in the mix, because these are considered to be tools that are planned to be widely available. And then there's a Canadian effort by Scott Hofer, for example, that will be, I think, adopted at least as a pilot in some of their large longitudinal dementia studies. Next. Getting, focusing further on some other web-based tools, particularly for cognitive or dementia screening. So here, in fact, the APT, or Alzheimer's Prevention Trial web study, Brain Health Registry. They have some similarities. These are a large part of their efforts focused on recruitment into trials. Now, one could think about recruitment into ADCs as well. These are using the Cog State Brief Battery on a tablet, and then also using either the CFI or ECOG as a sort of functional screener as part of that detection or identification of potential subjects for study. Next. I want to end by with just some comments about going beyond just the basic cognitive testing online or by video or even a telephone. This is just to point out, this is some work that we've been doing over several years now through our Orchitect Center and the CART initiative. The ability to monitor at home people's computer use over time is a sensitive measure of mild cognitive impairment, shown in the upper right corner. The ability to look at with a touch screen or on a computer, how a person answers questions every day, not every day, it could be every day, but on a weekly basis, can provide important contextual information as well. And so this then can be used to inform, as was brought up in the very beginning, about what if people are feeling depressed, anxious, and how it might actually affect how they are reporting when they give their, when you do their cognitive testing or clinical testing in general. Next. So I want to end by just some data. I thought this was, it just came from our monitoring in the CART study. So this is a collaborative aging research using technology study. People are asked once a week. They respond on their laptop, a tablet, or a smartphone. These are low-income seniors in the Portland metro area, and just showing how they respond on 2 items of that weekly questionnaire are about feeling lonely and depressed. And what you see are the uptick on when in our state, the announcement of a state of emergency and executive order to stay at home were announced. So you can see how these affected individuals remotely. Next. And then this is from the same study, the CART study, the MARS sub-cohort in that study that Lisa Barnes is heading, just looking at step activity. So this is collected using a wearable, a watch. And on the left of the panel is the person's just step counts from February through April of last year, and plotted over the weather, the temperature in Chicago. And then on the right panel is the same time period this year. And what you see is this very dramatic drop in steps in walking, which seems to correlate with the emergency measures that were put in place. And again, it actually doesn't seem to be affected by the weather. And so and then my last slide, or second to last. So the concept, please go back. So the one idea is going forward is I think we want to be able to immediately capture the things that we can do well. And I think the telephone assessment is the key. But there is this universe of other assessments, functional kinds of assessments that can be done in the home with an existing platform. And this is something that can be embedded into subsets of our center cohorts and pilot. I think that's what we really need to do. And that brings me to my last slide, and hopefully a segue into the questions, is that I think we really need to be clear on what we're trying to accomplish. Is it just replacing the the UDS as is to get novel assessments and then translating them into validating them, which is a lot of work. I do, as I said, believe that the telephone is really the best way, and I agree with the task force's recommendations, and actually I'm very thankful and congratulate them on what they've done. I think we need to get a better sense of technology use across our centers. And so I think having a more formal way of doing that would be important. I think we, as I mentioned, need to think more broadly than just cognitive testing. And it's going to take work. And I think we need to do in parallel the hard work now, because this doesn't, there's so many aspects of this that need to be not assumed, but objectively and carefully looked at, and hopefully we'll be somewhere. Actually, we'll be in the middle, even though that's a fantasy of this classic diagram of fast, cheap, or good. In fact, I would say that the task force has actually accomplished fast, cheap, and good in their preliminary recommendations for the short term. And with that, I want to thank you, and actually, I want to thank Elizabeth in particular for helping me and everybody put this together.
Fantastic. Thank you so much, Jeff. That was absolutely great. And my thanks to all of the speakers today. We have covered a tremendous amount that really is food for thought in terms of what we're doing to manage the short-term crisis, but also food for thought as we move forward to UDS 4.0 and beyond. So I appreciate for all of our speakers today, if they would stay online. I think we're going to move through and start.
I have the questions if you're good with that.
Yeah.
Okay. The first question was at the beginning of the session, and it came from Sandy Weintraub. So I'm going to unmute her, and she's going to ask her comment question.
Thanks, Cerise.
Hey. Okay, am I unmuted?
Yep.
Am I on? Okay, great. Thank you, Cerise. I just want to say what an incredible session this has been, because I thought after several hours in front of Zoom that I was going to zoom out, but this has been really a riveting set of presentations, and just goes to show us that necessity is the mother of invention. So I have a very practical question. Our team, and I'm sure others, have reviewed the T-Cog, and we had a number of questions about administration, the kinds of things that used to dribble in over the years for the UDS. How often can we repeat an item, and other fine points of administration and scoring. What would be the best way for us to share all of these comments?
I think, Andy, if you might want to chime in on that. I think he was trying to pass the buck to Suzanne, but I think it's helpful.
Exactly.
I think it's
Not great. It's not a good buck.
Yeah. No,
I
I can field this one because not 30 seconds had passed before Sandy had emailed me one of her typical, extremely thoughtful, well-articulated, voluminous list of questions. So Sandy, I think what's going to happen, your list had questions that are relevant to the T-Cog group about administration and repeating items. It also had questions that are relevant to NAC about data entry. So you can send them to me, and then I'll triage them, and I'll let you know where they're being triaged to, so that I'm not on the hook for not answering some of them.
So I was just wondering if there might be.
This is Mary.
Oh, I'm sorry, Mary. I'm just wondering if there might be sort of a central repository for all of these questions to come, as opposed to come to you pass them on.
I think that's a great question, and so I think that's an awesome opportunity for me to turf right back to Andy and Greg. So, but I do think it's a really good suggestion.
Yeah, I think we're
Can I
gonna.
just
I think we're going to need to pull this together, and I think one of the things that we can do is generate an FAQ, a frequently asked question portal from that as well. Let us get back to folks, but we'll generate a central repository for these incoming comments so that the working groups can stay focused on them and divvy up the responsibilities for addressing them appropriately. Mary?
So is this an opportunity for Slack? But I also wanted to I also wanted to comment that, you know, we, like others, have been doing exactly this battery, and we'll share experiences and try to tell you what our experiences are on those specific questions, because I completely agree. Despite that, we're moving forward, and you cannot deny how important that is.
Mary segue into my my response is that that's why we opened up Slack, and there's a clinical core channel, and we could funnel all of your comments there. To be an email
Yes,
box.
Suzanne.
So,
new technology. We all get smarter with new technology.
That's going to be good. So you can start there today if you sign up now. The next question was earlier in the very beginning as well, and it's from Adam Brickman, and I'll just read it and he can let me know if his question has been answered. But he says, he assumed that there's Spanish and other language versions of alternate tests, but what about the oral trails? Because the Spanish alphabet is different than English.
You know, I think Steve Rapp is probably the one who has the most, if he's still on.
Yeah.
I mean, they've given it in Women's Health Initiative to 20,000 people. So, Steve, is there a Spanish version?
There is not, that we're aware of.
No.
So that
There
would
is
be
not.
Yeah, that would be something not hard.
Maybe we can think about other executive function measures that would be more or less equivalent in Spanish as the oral trails in English.
Thanks,
But
Adam.
Adam, do you think that it might, I doubt we would be able to find these. It would be great if we did, that have some level of norms available. Do you think it might be easier just to try to create a Spanish version of oral trails? It's a fairly constrained task.
The alphabet is different in English and Spanish, and it's overlearned more so in English than in Spanish. We could take it offline on Slack.
Right. So could I also assure that we get the Spanish committee in on this, because
that's what I was going to say.
Executive tests are very different across languages.
The next question was from David Walt, and he asked if it's Tele-Video, would it be more reasonable to administer the mint?
So I just want to make a comment. Clinically, my local neuropsychology team has gone to the test that is being recommended by Suzanne. So I'm not sure that naming is the area that's most problematic. So,
yeah, I think we, as part of the initial UDS3 revision charge for the group, I think one of the things, you know, we've heard anecdotally from a number of centers, lack of finding the mint and the mint norms not the most helpful. So I think that was probably a test with a target on its back to begin with. So at any rate, that's a long-winded way of saying we could consider it, but we're pretty happy with the verbal naming test so far.
Remember, that's an optional item as well.
The next question is from Maria Carrata. When do you anticipate the COVID questionnaire to be ready to share with centers?
I think right now, Lisa, is it ready right now?
Well, I think we still need to vet it a little bit more in the committee. I don't think everyone was on board with the changes. So soon, but maybe one more discussion.
Hopefully in the next week or so.
The next question is...
Could I just add one more thing to that comment? As Lisa said, it had been translated, but then there were some further adaptations to it. So once it is finalized, we'll be sure to get it translated into Spanish for the final version.
The next question is from Sayed. They asked, given the potential future waves of COVID infection and superiority of video visits, would you agree the provisions for funding to obtain devices enabling video conference for participants who don't have means a worthwhile investment?
I think that's a question for you or Nina, Cerise.
Yeah.
So this is I just wanted to make another comment. You pointed to the study, the HBA study. I just wanted you to know we paid for every bit of technology that was installed in the homes of 600 individuals. We paid for the internet and the computers, etc. So that's what makes it doable.
Yeah, I would say there is funding available, but I don't know that we can do it for the tens of thousands of ADC participants, but it's something that we could consider on some level. And we need to learn how many people already have the capability. So that's embedded in some of the questions that are planned.
I would just quickly make the comment that there are different ways this can be done. Obviously, on the provider side or the tester side, the fact that all of us are doing this interactive conference means that we can probably deliver to homes everywhere, except it's the other side, the receiving side, that there's this great variability. And so if you have to distribute tablets, we've done studies where we mail the tablet out and then they actually mail it back. It's pre-prepared. It finds a cell signal. Well, there are places, in fact, that don't have great reception. But those are details that would have to be really carefully quantified and enumerated to really understand, how successful something like that might be.
Thanks, Jeff. The next question is from Beth Snitz. Any thoughts about the possibility of involving proctors, like caregivers and family members, for more impaired participants, or is current protocol assumed to always be administered without any proctoring?
I think Lisa or Andy as the co-leads for that cognitive group.
I think we started with the proverbial low-hanging fruit of the less impaired individuals, but it's certainly something that we ought to take into account in planning ahead for broader use.
Allison Lindauer had a comment. She wants us to encourage us to commit using telehealth instead of telemedicine because telehealth is more inclusive and has a broader scope of care. After that, Carrie had a note that for Rhoda during her presentation that they have a great number who own, including underrepresented minorities, but the underrepresented minorities use cellular plans where they pay by the minute.
Yeah, no, we've been actually, so I just want to say, one of the things that I've been looking at is sort of low sensor use, low battery use kinds of applications. So there are some, like I have one application that was in my presentation, CryptoWire, that only uses less than 10%, 2% of the smartphone battery. So we are going to have to move away from, as you say, sort of these high bandwidth types of activities into the much more low bandwidth. And I will say we have to make that transition. So we're not there yet, but we're pretty cognizant. And so one of the studies actually that we're trying to move forward with in a pilot basis is working with our Boston Medical Center patients, because Boston Medical Center is a safety net hospital for in Boston. So we serve very much the low income, actually the low income, non-English speaking, homeless population, et cetera. And so we're going to start working with them to try to determine what subset of applications are effective for use. So we're pretty aware that there are still some technological hurdles that we need to consider.
Rhoda, can I ask a question? Does your battery life response, is that the same as the minutes when people are paying for minutes?
So that's a good question. I'm not sure. Usually when you have battery, low battery, you're not using a lot of the bandwidth. So therefore you shouldn't be using it, but I can double check that. I mean, that's a good question, but I've always equated kind of the two a little bit together. Maybe incorrectly, I'll double check that.
And Rhoda, I think the next question is also for you because you mentioned about frequent testing. Carmen had a question if there was any concerns about practice effects.
Yeah, so actually, and Jason can probably speak a little bit more to his cognitive application, but the ones that I've been using, particularly the Dana application, is not subjected to practice effects. That's actually, right now we have an SBIR grant that we're doing with the creator of that application to test frequency of use. They've already done it in other populations. We're doing it with the BU Alzheimer's Disease Center cohort. And we're actually going to be testing, just to let you know, the frequency is going to be 3 times a week, then we're going to move to weekly, and then we're going to move to monthly. And so it literally is sort of a study to test of also feasibility of doing much more frequent short burst testing, which again, I think that Jason has probably even much more experience than I do on that.
The next question or comment was from Howie Rosen, and for Rhoda or Greg, he just wanted to let you know that they're rolling out the platform that Jason is developed for all FTD very soon, and we've already done some pilot testing that's continuing.
That's great.
Kate Postine said that Rhoda has a very exciting presentation. Giving our focus on older adults, how do you minimize the impact of visual acuity issues? Relatedly, do you strive to standardize stimuli presentation size across the devices?
So actually, that's a really great question because we also are addressing that right now with the same company, Anthrotronics, with the Dana application, because we also pointed that out. And so we literally they're like working on that feature right now to see if we can enlarge it without affecting sort of the quality of the testing itself. So that's probably more of a to be determined, but it is something that we're pretty aware of.
Judith had a question about smartphone usage. At her institution, they found that particularly in underrepresented groups, that issues of data usage and telephone has been an issue. Never mind, we answered it. I'll do better. Okay. Charlie had a question about for K about rapid dropout is something that they have seen at Davis and would likely to worsen with our older individuals. What? No, I don't want that question. You answered that one. Ann Arthur had a question at the beginning of the meeting. Can the T-Cog be administered video conferencing, Zoom? The MOP only mentions administration by telephone.
I guess I'll field that one. We have carried out a few Zoom assessments just as we're trying to ramp up for this larger pre-validation study. And in that study, we'll try to do half of the T-Cog, the T-VCog or the VCog by Zoom and the other half by telephone. So that's to date, all we've done in sufficient volume is telephone, and that's why the MOP focuses on telephone.
Therese, this is Cindy Carlson. Could I just make a comment on the use of video platforms that was raised by others in some of the questions too, and that video platforms are not all HIPAA compliant. So from my understanding, our University of Wisconsin IT team has looked into Zoom and it's not HIPAA compliant. So as far as widespread use, we'll have to see. I think Video, the VIDYO, and the Doximity are 2 platforms that are HIPAA compliant. But again, these things will need to be vetted. The telephone is the easier question. That's been done for a long time for our telephone visits. But again, I think the video, before we endorse anything widespread across the centers, will have to be addressed.
Yeah. Could I just add, I'm not sure that they're all comparable either in timing, and so I think that's a very big deal. So data collection probably has to collect exactly what platform.
I also just quickly want to make the comment that there are different versions of these products, and you pay more for, you can get more secure and more, and so this is something that also would go, I think would go into our survey of centers about, you know, what are their, you know, what systems do they have available? Are they, do they know, and so forth.
The next question is from Joel Kramer. Do scores from the T-Cog go straight into the NAC database?
So that's something that we're working out now, where I believe Bud's on, so maybe he could address this more directly, but I believe the plan is that there will be a way to enter them into the ANAC database, but make it distinct that they are not, that they are T-Cog and not in-person data. I don't know.
That's right. And Bud will be speaking after the lunch break on that aspect of the T-Cog and the entire telephone packet. So we should probably hold that question until we hear what Bud informs us on in the afternoon session, because that may just answer the question right off the bat.
Liang from MGH had a question, and there's some other questions about cheating. And just let me know if, raise of a hand if they're answered or not. But her question was, what concerns about cheating if administering tests over the phone or versus via video? So if you can give a brief answer for that.
You want me to take a swipe at that?
Sure.
I'm not sure I heard the question. Is what to do about cheating?
Yeah.
Yeah. Well, what we have been doing is addressing it quite explicitly with participants. So we ask about specific aids that they might have in their presence, pads, calendars, clocks, etc. And if they say yes, we ask them to remove them, turn them around. That includes the phone. If they're using a smartphone, we ask them to flip it over so that they can't see the date. We also tell them that they have, that all of this has to be done in their head, and then we cross our fingers and hope that they don't cheat. I think that there are some participants who do. We've had some in the Women's Health Initiative memory study confess to us that they do, but that's at least what we do to mitigate that problem.
Yeah, I can tell you just this,
go ahead.
you know, we did the telephone mini mental at Framingham years ago, and we ran into the cheating problem. And it gets worse when you do repeat assessment, because now they're expecting it.
Carrie Gleason had a comment. We too have questions about recommended order of administration when the RAVLT or any word list is included, and concerns related to inferences from fluency tasks and the MOCA word list. And she's volunteering a separate call to work through these questions or issues. And I also will tell Carrie to use Slack, and you can start a thread. So that could be done right now. Liana had a question earlier in the session. When should we start the implementation of the telephone battery? Logistically, her questions are, should we wait a little longer, see things how they go with the research of clinical and research activities? And so timing, I think, is her question in general.
So I just wanted to respond to the earlier question. I think we have agreed to move those technical questions regarding the T-Cog battery over to the Slack channel. We'll try to address them with the combined expertise from the Wake Forest group and others on the committee. And then I think in terms of timing, Greg may want to field this also, but I mean, I think each center has to look at the specific issues in their cohort and make some decisions about that, unless there's overall program guidance.
Andy, I agree with that completely. You know, we want to take on a uniform approach, but we understand that the issues that each center is facing are quite different. There are some centers, as I mentioned, ours, we're looking at maybe a June restart up. It may be much longer in our centers in New York City and other hard-hit areas of the country. So that decision is really something that we're relying on the individual centers to use your best judgment for the safety of your participants and for the preservation of the best data that we can continue to collect.
This is
Greg, could I just make one additional point, which is something Cindy said, which is right now we are not using the T-Cog for baseline assessments. And you know, Cindy said that the clinical telephone materials, excuse me, aren't being used for baseline assessments either. So I think that's a a recommendation we might want to put forward
and
to
Susanna,
preserve those baseline data.
I will chime in as well, is that we are actively working on an initial visit telephone packet, realizing that that may be suboptimal, but as soon as we can get somebody in for an in-person evaluation, we hope to roll that out in the next few weeks. Right now we're starting with the follow-up visit packet, but we are already turning our eyes towards that initial visit telephone packet for many of those centers that expect a potentially prolonged period of time until they're able to start back up in a traditional sense.
This is Cindy. That was one of the questions for the group, but also the other thing is at our University of Wisconsin Alzheimer's Center, we're finding from participants that many of them are hesitant to come back even if we do open up in July. And so I think that having a telephone-based remote tool that's standardized across centers we can use. Again, some centers may open up and start doing in-person evaluations, but for those centers who either have delayed startup again or participants who are hesitant to come in because of their concern about being a medical center, we may want to look at other community-based places where they can go to be evaluated and or continuation of the telephone-based or video-based assessments until they can ramp up again to the full in-person assessments.
Well, that would be great.
So
we can discuss more, in the CTF, because I mean, I am hopeful that we would be able to use the T-Cog. We're starting the pre-validation right away, so that we would be able to have, after some period of time, not too far, after a year or so, some good normative data that might help us translate it. And what we found, we've been using just the clinical UDS methods, and it's really tough to adjudicate, for example, MCI without those cognitive scores. So at the very least, we've found that the T-Cog is great with respect to allowing us to adjudicate, maybe not using the scores as numeric values. So I think there's a lot of merit in that, and definitely something we can accelerate.
I just want to add, if you're listening to the news, we might have another surge in the fall. So being able to use the telephone cog will be a very good thing. And given the work that NAC is going to put into building out the database, we don't want to just throw it away.
So can I just add one other thing? I'm hoping that we consider the length of the assessment, because as you saw, the length of the assessment is really the biggest thing that people disagree with. And we've assessed with a patient separately from an informant, and you may not always want to be doing that. So I think anything that gets added, it might only be 7 or 12 or 10 or 11. We really have to be very careful about that. And I think measuring it will help us know where we hit the limit.
So Mary, that's part of why we're piloting both just the core T-Cog and the core plus supplement, because that will help us see how well tolerated the longer version is, because I think you're absolutely right. It's very difficult to get people to give you valid information in a really long virtual visit. So,
right. And oftentimes it's multiple phone calls, but they do get impatient after a while. So we really have to be sensitive to that.
Suzanne, did you have any plans to pilot the COVID questionnaire while you're doing that?
Yeah, we'd love to do that. I mean, we might as well. We are actually doing another stress ancillary study that will sort of partner with this. So yeah, I think we would be happy to do that.
That'll be really helpful.
Yep, we're hoping we'll be able to get started within a few weeks. So we can talk offline, Lisa, about that, or maybe on Slack.
Suzanne is getting it. Okay, I just want to wrap up some, I want to encourage the panelists to go into the question and answer session and answer some of the questions that have not been asked. So please do that. Or, acknowledge these comments in there's 19 open questions. People have, we were talking about HIPAA compliance, and people have mentioned that there are health versions of Zoom that may be HIPAA compliant. And Blue Jeans, I think, was another one that is a video platform that's HIPAA compliant. So the compliancy issue could be solved. It also, panelists, in the comment boxes, there are people who are eagerly willing to volunteer, either doing translations or with the COVID survey. So please take note of that. And if there isn't any last minute questions, I think that we'll let you break for a bit to come back at 2:45. Ooh, silence.
Fantastic. Thank you, Cerise. Thank you again to all of our presenters and all the feedback and wonderful input from the ADRC attendees today. Cerise, thank you for managing that Q&A session.